Good morning, everyone. This is Mark Erkin joining you from New York, and we welcome you back to our Friday morning Thyroid MDS program. We have a truly wonderful panel of experts this morning, and a truly international panel of experts to delve deeper into the topic of active surveillance, and in particular to discuss how patients select optimal care for their early stage cancer. Our presenter this morning really needs no introduction. Actually, none of our presenters do, but I'm going to go ahead and take the liberty just to introduce Dr. Anna Sawka, who is an associate professor at the University of Toronto. She's an endocrinologist and clinician scientist at the University Health Network in Toronto. She completed a PhD in clinical epidemiology and biostatistics at McMaster University, and she has received research grant awards from the Cancer Care Ontario Health Services, Canadian Institute of Health Research, University of Toronto, and Canadian Cancer Society Research Institute. Her research focuses on thyroid cancer treatment, medical decision-making, and quality of life, and that will be largely our topic this morning regarding medical decision-making. We also had the honor of being joined by Dr. Rossella Elisei, who has presented on this platform in the past. She is associate professor in the Department of Clinical and Experimental Medicine at the University of Pisa. She has had a very robust academic career that has included participation in multiple clinical trials aimed at advancing drug therapy for aggressive thyroid cancer. She's an active member of the editorial board of Thyroid Journal, the International Journal of Endocrine Oncology, and the European Journal of Endocrinology. And we have the honor again of having Dr. Eyal Robenstock, who's an endocrinologist at Rabin Medical Center and is the head of the Thyroid Cancer Service at the Davidoff Cancer Center. In recognition of his scientific achievements, Dr. Robenstock was awarded the Lindner Prize of the Israel Endocrine Society. He has contributed immensely to Thyroid as a member of the board of directors, the International Leadership Committee, and as educational liaison of Thyroid. And so at this time, I'd like to turn over the program to Dr. Sawka and encourage all of you this morning to send in your questions. And at the end of Dr. Elisei's presentation, Dr. Robenstock and I will do our best to get to those questions. So everybody, thank you for joining us. And Dr. Sawka, the program is yours. Thank you very much.
Well, thank you for that kind introduction. Thank you for inviting me to present at this virtual journal club. I'll just give a couple updates that from the intro is they're kind of very new, but I was promoted to professor, so that's kind of a new thing, and I'm now editor of Thyroid. So I just kind of wanted to mention that. And what we'll be discussing is active surveillance of low-risk papillary thyroid cancer. These are my financial disclosures, including peer-reviewed funding agencies and editor of Thyroid. So our paper is a quantitative analysis examining patient choice on active surveillance of surgery or surgery for managing low-risk papillary thyroid cancer. And this was actually initiated in Toronto, Canada, and now is kind of expanded more to a pan-Canadian study, but we'll talk about our initial Toronto experience. So the fundamental components of active surveillance in small, low-risk papillary thyroid cancer are to avoid or defer initial treatment, which would be thyroidectomy, and closely monitor the disease, in this case, the cancer, with clinical assessments and diagnostic tests, which would specifically include ultrasound imaging of the neck. Another important component is there are predefined disease progression criteria for salvage therapy, and that salvage therapy would be with curative intent. This would be, of course, surgery. And of course, this field of research and now this area of care was first studied in Japan, and it started in Kuma Hospital by Dr. Miyachi in 1993, followed in 1995 in Tokyo by Dr. Sugitani. So we're really, a lot of what we've learned about active surveillance is to be credited to those institutions and individuals. In terms of general considerations for active surveillance, we generally would consider what we would say is a small papillary thyroid cancer. And what small is somewhat debatable. It started as papillary microcarcinomas in the original studies from Japan. In our study, it's papillary thyroid cancers under 2 centimeters, and in some studies under 1.5 centimeters. But generally, this would be considered T1 in terms of the primary tumor. We also want the tumor to be confined to the thyroid. So we would not consider a tumor where there's extrathyroidal extension, clinical nodal metastases, distant metastases, and it needs to be fairly easily visualized on ultrasound, as that is the primary modality by which we would be assessing for progression. The other thing is one needs to consider location. And here's a lovely diagram from one of Dr. Miyachi's papers in 2016. And essentially, we want to consider that the location is not at high risk for invading the trachea or recurrent laryngeal nerve. And there's some technical aspects to this that are outlined in this paper. Also, general considerations have been outlined by Brito et al. In Thyroid. Now, in terms of where clinical practice guidelines are, active surveillance has become a standard of care to be offered in Asia, as it's been practiced there for many years for particularly for papillary microcarcinoma. And in the American Thyroid Association guidelines that were from 2015, published in January 2016, it wasn't really a formal numbered recommendation, but there was some text indicating that it may be considered in the following patients. And the one that we're going to highlight today is very low risk tumors. This would be papillary microcarcinomas without metastases or local invasion, and no evidence of aggressive disease. Some of these other ones, where they talk about high surgical risk because of comorbid conditions, expected relatively short remaining lifespan, or concurrent medical or surgical issues that need to be addressed prior to thyroid surgery, that may be a little more debatable as to whether that would be labeled as active surveillance or watchful waiting or deferring until treatment. But this is really the group we're going to focus on, is group A, albeit with including a slightly larger tumor size. The American Association of Endocrine Surgeons in 2020 also came out with a recommendation regarding active surveillance and indicated that active surveillance protocol for papillary thyroid microcarcinoma may be appropriate for carefully selected, informed, and compliant patients. And this was a strong recommendation based on moderate quality evidence. And I guess really what our study is about is looking at, how do you select these patients, and can they, to some extent, self-select themselves if you have appropriate eligibility criteria? And then in the long run, looking at compliance and outcomes. But we'll be talking today about kind of that initial process of decision-making. So in the Toronto active surveillance study, essentially this is a prospective observational cohort study, and we referred to it as very low risk papillary thyroid cancer. So papillary thyroid cancer under 2 centimeters, and again, confined to the thyroid with no obvious high risk features. We did not assign intervention, so it's not technically a clinical trial, it's an observational study, but we did register the protocol. And what happened with the study is we had to cobble together funding from a number of sources. And first of all, we needed to figure out whether Canadians would even be interested at all in active surveillance over surgery, as surgery has been the well-established standard of care in our country. So we needed to first do a study to figure out how often patients would choose active surveillance if they were actually given the choice, assuming they meet sort of eligibility criteria from a medical perspective. And then you really don't know what that number is going to be. So we had a separate sort of funding and separate kind of component to the study, where depending on whether they chose active surveillance or surgery, we followed them for the same kinds of outcomes. But again, we couldn't really know how big each of these respective groups would be because they weren't assigned arms. So it was not randomized, we didn't assign anything, and it was very much so encouraged for patients to be involved in the decision. So that led to some kind of interesting components when we were designing the study. As we've been doing this since May of 2016, this has also led to now a pan-Canadian study looking at long-term outcomes, which is registered at clinicaltrials.gov. Again, where we're not assigning groups, but watching what happens to people after they decide their treatment or disease management. So I guess the question is, how did we start this study in Toronto? Why did we start it in Toronto? There's actually a very good reason for that. And Toronto is a hotspot in Canada for diagnosis of thyroid cancer. In fact, this was a study by Corsten et al. That was published in 2015. Here we see an incident rate ratio of 1.00 for Toronto, and we see that up to essentially 1.5 to almost 3 times the incidence of other major metropolitan centers throughout Canada. So this was, we were seeing a lot of papillary thyroid cancer. We were also seeing a lot of low-risk disease. And we felt that we needed to look at strategies to avoid potential overtreatment and expand disease management options. So again, our design was a prospective observational cohort study. Important, we did not assign or randomize patients, and the decision was by the patient, although the patient could incorporate their physician's advice, of course, if their primary care or referring physician had any specific advice related to that. In the first part of the study, we were looking at the primary outcome of how often patient chose active surveillance, and the study was essentially powered to look at sort of a almost a survey study where you're looking at sort of accuracy of that measurement. And we did have a hypothesis that we actually thought that more than half of patients would choose active surveillance if they were actually given the choice. We also did some secondary analysis, so logistic regression analyses, looking at multivariable analyses for looking at predictors of whether patients chose active surveillance or surgery. Patients performed baseline questionnaires, so this is prior to really meeting with the investigator. So they received standardized information, specifically indicating that surgery was the standard of care, the risks and benefits of active surveillance or surgery based on literature with references, implications for and uncertainties related to pregnancy and follow-up procedures. It is important to note that in patients who chose surgery, surgery would be performed by a surgeon of their choice, and it was not necessarily performed in our institution. We certainly did not mandate that. And after they had decided which, so the patients were offered information, assuming they were eligible. They were interviewed by a research assistant, and they provided insights on their decision, both quantitative questionnaire and a small qualitative interview. And we supplemented this with medical record review at the beginning, and if there was a change in management, as well as yearly. In terms of our inclusion criteria, these were all adults, and they had to have untreated papillary thyroid cancer or suspicious for papillary thyroid cancer cytology on fine needle aspiration biopsy, tumor size, primary tumor size under 2 centimeters. And in terms of the multifocality, that was not an exclusion for surgery. Exclusion criteria: risk for recurrent laryngeal nerve injury or trachea if their location was considered too high risk, spread outside the thyroid, be that extrathyroidal extension, nodal or distant metastases, if there was a suspicion of poorly differentiated or non-papillary thyroid cancer, if they were medically unfit for surgery or pregnant at enrollment, although patients were allowed to become pregnant in the course of the study, but this would essentially intensify some of the follow-up during and after pregnancy. But we did need baseline measurements of their primary tumor when they were not pregnant. So they could enroll after a pregnancy, for example, if they were pregnant and newly diagnosed. And there was a couple of amendments we actually had to do, in that originally we planned to exclude patients who had any malignancy other than sort of basal cell skin cancer diagnosed within 3 years of the papillary thyroid cancer. But what we actually found was that there was other patients who had cancers that were, for example, prostate cancer under active surveillance or other low risk cancers who really had an excellent survival expectation, who wanted active surveillance. And so we did amend that. Similarly, for individuals who had Graves' disease, for example, medically controlled mild hypercalcemia, not meeting surgical indications for with respect to hyperparathyroidism. Those patients were also interested in their surgery, and they didn't really have an absolute indication for having a neck operation. So we did amend our REB because of both patients and physicians advocating for such patients to have the opportunity for active surveillance. And of course, their other issues were followed by other doctors, but it was important to note that we had to evolve to the needs of our population. With respect to the active surveillance patients, these patients had follow-up every 6 months with ultrasound, blood work, and physical exam every 6 months for 2 years, and then yearly. We actually had to do a COVID amendment because a lot of the clinics were closed in the COVID pandemic, and so we had to, we were permitted to essentially do virtual care, but patients still had to come to our institution for the ultrasound. The other important aspect of this is that even if the patient under active surveillance did not meet criteria for surgery, but essentially wanted to have surgery, they could change their mind at any time, and they could have their surgery performed by any surgeon they wanted to. We did request some medical records related to the surgery and pathology, etc., but we did not restrict where surgery was performed. And salvage surgery was recommended if the papillary thyroid cancer in largest diameter grew more than 3 millimeters, but we confirmed this on 2 consecutive ultrasounds. And again, this was centrally performed at our institution. Incident development of metastatic papillary thyroid cancer to lymph nodes or elsewhere, extrathyroidal extension suspected on imaging or concerning location of growth, or incident distant metastatic disease. So again, those would be criteria for salvage surgery, which would be with curative intent. As for the patients who had chosen surgery, or the patients who crossed over for surgery, essentially, they were essentially a usual care arm. So their treating physicians decided on the extent of thyroidectomy, radioiodine, TSH suppression. It was all at the discretion of their treating physicians, kind of I guess a real world sort of aspect to the study. And we really did not mandate specific clinical procedures, but we also knew that the type of physicians that were referring to the study were individuals who were experienced in the field. And so we knew that these kind of standards like TSH, thyroglobulin ultrasound, et cetera, were regularly being performed in these patients, many of whom were actually cared for in our institution, but again, they could have their care elsewhere. In terms of the baseline questionnaires, these were performed prior to meeting the investigator, demographic characteristics, past history, family history, and we did a number of psychological questionnaires, including a questionnaire on coping style, fear of disease progression, surgical fear, but surgical fear is a general questionnaire. It was a short form questionnaire, and it really lacked some questions specifically related to thyroid surgery. So we actually did add, but scored them separately, 4 questions that we thought would be relevant to thyroid surgery in particular, and scored them similarly and sort of formatted the questions similarly, but these would be unvalidated. So one of them was being afraid that my voice may change because of the operation. I will need to take thyroid hormone because of the operation. My blood calcium will be low because of the operation, or being afraid of how the scar will look after the operation. So we really felt like we needed to tap into those questions, but really couldn't find a questionnaire. So in terms of baseline, we also asked them, right, essentially from when they consented to the study, is what would be their disease management preference if they were offered a choice of surgery or active surveillance. So patients had to sort of provide an answer to that question, even before meeting with anyone or getting any sort of information from investigators. We also did a decision self-efficacy scale measurement, which essentially measures the confidence that the patients have in participating in their decision, in this case related to papillary thyroid cancer management. And after they had finalized their decision, we evaluated their satisfaction with that decision. And we also asked them who really made that final decision, who was responsible for it. Was it the patient, the doctor? Was it shared by both or someone else? So we were interested in finding a lot more detail about how the process of that decision. So we assessed 260 patients. Our target was 200 patients for enrollment. We did have to exclude some patients for not meeting inclusion criteria. Interestingly, only 20 patients declined to participate. We assessed for enrollment essentially consecutive patients in our institution, but those included some patients that were referred from outside institutions, which of course can result in some referral bias. So, and I'll talk about that a little bit more later. So we had 200 patients. 155 chose active surveillance and 45 chose immediate surgery, and we had complete data. So we did not have any missing data. And this is a table summarizing the characteristics of those patients. So we see that the majority were women, median age, all participants 51. But in the active surveillance arm, you can see these are a bit older than the patients who chose surgery. Tumor size median was 11 millimeters. And about 56%, oh, sorry, let's see, previous. 56% had a tumor that was larger than a microcarcinoma. At the time the study was going on, and to some extent still now, I think that a lot of these tumors that are under a centimeter, which were not recommended for biopsy in the last ETA guideline, still were being biopsied. I think we're seeing less of those now, but it certainly was happening at the time we've been enrolling patients. This is the, most of them had papillary thyroid cancer, 29% had suspicious for papillary thyroid cancer. And in the initial study, we had actually insisted on a central cytopathology review. And we found that as we kind of went along that this was really not necessary, especially for when receiving specimens from other institutions that showed papillary thyroid cancer. So we actually did have an amendment to increase efficiency of the study to in that we really found that it was unnecessary to have a second review when things were obvious and from a trustworthy institution. Most patients were not taking thyroid medicine and had normal thyroid function. And as you can see, 71% of the patients were actually from our institution. Multifocal nodules, so these are not necessarily multifocal cancers, in about 3/4 of patient. And for the primary outcome, which was how often patients chose active surveillance, we found that about 3/4 of the patients who were given this choice chose active surveillance over surgery. And it was clear to them that surgery was the standard of care, and this exceeded that lower confidence interval threshold of 50% that we had hypothesized. Now, in terms of disease management preference, it's very interesting to note that these patients, for the most part, knew what they wanted before they even saw the investigator. So 78% of patients favored active surveillance when they were asked right at the beginning, after being consented, what would you choose if you were given the choice? And participants' preferences rarely changed after meeting the investigator. So three patients, 1.5%, who favored surgery initially, crossed over to and chose active surveillance ultimately. And 4 patients who favored active surveillance ultimately chose surgery. So most of these patients really knew what they wanted even before any formal, I guess, counseling, so to speak. In terms of their decision self-efficacy, and I think this is sort of a complementary result, we see that this 93 out of 100 is really a very high level of confidence of these patients in making their own medical decision related to this, this particular treatment choice. So patients were very confident in making a medical decision, and they rarely changed their decision even after seeing the doctor. Interestingly, they were also highly satisfied with their decision. So after they finalized the decision, we asked them how there's a validated questionnaire on satisfaction with decision, and 96% of patients had high satisfaction with their decision. When you ask them who made that final decision, 86% actually reported that they took responsibility for the decision and they felt that they made it themselves. And this is actually quite a high percentage. I've done prior research on radioiodine remnant ablation decision-making in low-risk thyroid cancer, and this really kind of exceeds that. So with respect to this decision to have an operation or not, patients really, in our study anyways, were the ones who largely made that decision. 14% of patients really attributed to that decision to both the patient and the doctor sharing it. None of them felt that the doctor told them what to do or someone else told them what to do. So those were some interesting findings. And in terms of demographic and clinical predictors of active surveillance, this is kind of a busy table. It's from the manuscript. I won't go through it in detail, but basically we did a univariate analysis and then multivariable analysis looking at what might predict the patient choosing active surveillance. And here's some interesting data on age. So what we see is the older the patient was, so this is compared to individuals less than 40 years, an individual in their 40s to 64 was almost 3 times as likely to choose active surveillance over surgery. And an individual over 65 years was about 8 times as likely, and those were highly significant. So older individuals tended to favor, and actually significantly favor, active surveillance over surgery as compared to younger individuals. Interestingly, education, being lower, was associated with the choice of active surveillance. And one could think about a number of ways where that could be related, perhaps related to socioeconomic status. But this was actually inverse. The more education, the less likely to choose active surveillance. And another one that I mentioned, potential referral bias before, because we did have about 29% of patients came from other surgeons. So patients who were actually enrolled in the study consecutively in our institution were less likely to choose active surveillance than the outside ones. And I think that probably this is reflective of the fact that if a patient is going to actually travel to another institution, see another set of doctors, then they're probably most likely going to be making that trip after seeing another doctor if they're actually interested in something they can't get at the other institution, which is active surveillance. So I think this is a reflection of referral bias, but interestingly, we're able to quantify it to some extent anyways. The psychological questionnaires, again, this is a secondary analysis, but it was something that we did plan upon, is actually quite interesting. So in this, we looked at the psychological questionnaires and how that predicted choosing active surveillance. So we can see that with respect to fear of progression of their thyroid cancer, patients who feared the disease progressing more were less likely to choose active surveillance. So that makes sense, and it's actually supported by qualitative literature that we and others have published. One really interesting question was the one that we had added about needing to take thyroid hormone because of the operation. And if patients were fearful of having to take thyroid hormone, they were significantly more likely to choose active surveillance over surgery, but actually general surgical fears and some of these other surgical specific fears were not significantly related. But the one that really stuck out was having to take thyroid medication. In terms of the coping questionnaire, it's kind of a complicated questionnaire, but there's a number of these different domains, but the one that was significantly associated was active coping. And this is essentially a description of someone feeling that they want to do something, they want to take action. And patients who wanted to take action and had an active coping style, not surprisingly, were more likely to choose surgery over active surveillance. So it kind of made sense, actually. Now, in terms of limitations of this work, we did have to make REB, I guess in US you would call IRB, approved protocol amendments in the course of the study. We were starting a new protocol for essentially an active surveillance program, which had never been done in our country. We had to sort of be responsive to patients and physicians' interests in expanding the eligibility criteria, partly because of popularity and patients wanting to have this opportunity and their doctors advocating for that. We also had to make changes related to the COVID pandemic and accommodations for virtual care. And it actually seemed to work out fairly well. But of course, as with any study, we had our challenges with recruitment at times when clinics were closed. We also lacked available validated questionnaires for some of those thyroidectomy-specific surgical fears, including fear of going on thyroid medicine. So we did our best in formulating some questions, but they really are not valid. We could not find any validated questionnaires. I already mentioned several times the potential referral bias, as referring physicians were more likely to preferentially refer patients who preferred active surveillance, or perhaps those who declined surgery already. So this is an important limitation in our study, but at the same time, it allowed us to incorporate patients from other practices in the Toronto area, and also to allow more patients to have the option of active surveillance if they wanted it. And another component beyond the city of Toronto, it is our data may not be generalizable outside of this area region and to other healthcare systems, as we are in a publicly funded healthcare system. And we did not record or in any way patient or physician interactions. So we don't really know what exactly was said at these interviews by physicians, but we focused on patients' perceptions. So in summary, we had 200 patients with small low-risk papillary thyroid cancer offered surgery or active surveillance. About 3/4, when offered this choice, chose active surveillance. Predictors of active surveillance being chosen were patient older age, less education, and the surgeon hospital affiliation outside our hospital. Psychological predictors of the choice: more fear about cancer progressing, patients tended to choose surgery. More fear of taking thyroid hormone, patients chose active surveillance. And patients who had an active coping style and felt they needed to do something were more likely to choose surgery. This is a list of the collaborators, and this is an early list, and it has expanded, but it was kind of all I could fit on a slide for today. So I also wanted to especially mention Dr. David Goldstein, who is a head and neck surgeon at University Health Network, and he's been a co-primary investigator with me on this study, and our radiology lead, Dr. Sangeet Ghai, also our research staff, Mr. Ioannidis and Mr. Ihakir. And this has led to, I won't discuss in interest of time, but a multi-center pan-Canadian study looking at long-term outcomes in active surveillance or surgery. And again, this is not a randomized trial, but a prospective observational cohort with patients deciding their disease management choice. There's a list of our funding and some references in case that may be of interest related to this study and the ongoing one. And that's everything. Thank you.
So Good afternoon to everybody, good morning for you, and thank you for this invitation. So I will talk about active surveillance as a new appreciated strategy, and I will share with you our own experience. I will go very quickly on this first part of the discussion because many things have been already said by Dr. Sawka. First of all, what we mean for micropapillary thyroid carcinoma. With this term, we specifically identify an intrathyroidal papillary carcinoma measuring less or up to 1 centimeter. How much frequent they are, and are they really indolent? Well, recently, a very nice meta-analysis of autopsy studies has been published, and dividing the percentage of micro-PTC found at autopsy in different groups of age, the authors clearly demonstrate that more or less these prevalences were very similar, with a very insignificant difference. And as you can see here, the mean is around 12.5%. So micropapillary thyroid carcinoma, indolent micropapillary thyroid carcinoma are very frequent. And interestingly, at the difference with clinical papillary thyroid cancer, it seems that there is no difference in its incidence according to age, and also there was no difference according to sex. Male and females had the same ratio of micropapillary thyroid cancer at autopsy. Regarding the indolent course, there are several studies, but probably this is one of the most relevant for the number of cases that have been analyzed. Data have been retrieved from the SARE database, and as you can see here, almost 30,000 patients with micropapillary thyroid cancer were identified, and their probability of survival was even better or greater than general population. So it seems that micropapillary thyroid carcinoma has per se an indolent behavior. These are the results of the pioneers studies from our colleagues and friends from Japan. Dr. Sawka already told about this study. These studies are the longest at this time, with the longest follow-up, and they clearly demonstrated that only a relatively small percentage of cases of micropapillary thyroid cancer under active surveillance required to be operated because of the growth of the nodule, and even less for the appearance of lymph node metastasis. Then over the years, other studies have been published on this specific issue, of course with shorter follow-up. This is a study from a cohort from Latin America. And again, as you can see here, the prevalence of cases increasing in a follow-up of 1 year or few months over 1 year was similar to that of Japanese series. And then there is another study in which the size of the tumor included was a little bit bigger, and a certain percentage of cases were bigger than 1 centimeter. So it's a series in which the concept of micropapillary thyroid carcinoma or low-risk papillary thyroid carcinoma has been increased, and also bigger tumor have been increased in the series. which are the, let's say, the issues or the features that we want to take care in enrolling patients in active surveillance program. Age. Age seems to be something relevant. These are the data from Japanese, and as you can see in both graphics, on the left regarding the tumor enlargement and on the right regarding the development of lymph node, by dividing patients according to the age at diagnosis, you can see that the percentage of increasing cases is higher in younger patients. But please note that we are still talking about 6% of cases in both situations, both in case of enlargement of the tumor and in case of lymph node metastasis. So it is true that patients over 60 have a lower probability to enter into progression, but also for younger people, the prevalence of cases entered into progression is rather low. And this is a meta-analysis of 5 studies on more than 2,300 patients with micropapillary thyroid cancer, clearly demonstrating that older age may be associated with a reduced risk of papillary thyroid carcinoma growth under active surveillance. And in any case, the incidence of metastatic disease is very uncommon. However, some authors have some concern about the story of age, because young people, of course, have a greater lifetime probability of disease progression. So in young people, as you can see in this picture, in this figure, especially during the second and third decade, there is a higher probability of growth, but then over 30, this probability is maintained similar to those of older people. So probably the difference in the increasing number of cases entering through progression is related to the estimated lifetime probability of micropapillary thyroid cancer progression. Another issue is pregnancy, because some of our patients who choose active surveillance are maybe in the fertile age, and they can have pregnancy during the active surveillance. This is a report of Japanese colleagues in which they had 4 cases out of 50 pregnant women who showed progression. That means that only 8% of pregnant women had a real progression during the active surveillance. They were operated after delivery, and the thyroidectomy was curative. If you want to look at the vice versa, 46 pregnant women did not show any progression of their micropapillary thyroid carcinoma. The TSH value. Can the TSH value have a role in the progression of the micropapillary thyroid carcinoma? These two studies have a controversial result. In the study of Sugitani, there was no significant association between TSH and micropapillary thyroid cancer progressions, while in the study of Kim, an elevated and sustained elevation of serum TSH during active surveillance was associated with micropapillary progression. Probably the difference is among the value of TSH that in several cases of the KIM study was higher than 2.5 microunit per liter. Anxiety. Anxiety is another, let's say, issue to take into consideration. In this study, Dr. Davis conducted a questionnaire survey for patients with micropapillary thyroid cancer during active surveillance at Kuma Hospital. And a lot of them, the majority of them, respond to the questionnaire, and the results were that 37% replied that they have cancer worry sometimes. A big percentage of patients replied that the worry decreased over time. And the majority of them replied that choosing active surveillance was the best decision for them. This means that there is a kind of reduction of the anxiety during the active surveillance. And probably this study, very recently published, can respond to the all questions about anxiety. These are two groups of patients. In orange, patients that were let's say treated or with active surveillance, and on gray, with gray, the patients who choose immediate surgery. The level of anxiety was significantly lower from the beginning in patients who choose active surveillance respect to those who choose immediate surgery. And the level of anxiety was maintained in the two groups. As you can see, the two curves are perfectly parallel. What about our experience? We started in 2014 a study approved by our local ethical committee. The inclusion and exclusion criteria are very similar to those that Dr. Sawka already described for her study, with the difference that we really included only patients with micropapillary thyroid cancer. We screened 185 patients, and almost 50% accept to be enrolled in the study. I want just to stress that this was a kind of a pioneer study in our country, and in the beginning it was not so easy like it is now to have patients choosing the active surveillance for their own choice. So these 93 patients were followed up until the publication of the study and are still ongoing followed. In about 6 years, 20% of patients drop out, and the reason were in the majority of cases for personal choice, in a relatively high percent of cases for disapproval of family members, or even for disapproval of other physicians. It is important to note that the dropout, here represented by blue lines, happened in the majority of cases during the first year of enrollment. What about the follow-up of these patients? We had only 3 out of 74 patients with disease progression, 1 for lymphadenopathy and 2 for nodular enlargement. And this study for us was clearly showing that active surveillance is safe, feasible also in our countries. A careful selection of patients is mandatory. We should avoid to have a dropout in the first year of enrollment, because it means that patients were not really convinced to perform active surveillance. Only 3% of them showed the disease progression, and the lying surgery had no impact on their outcome. And making a comparison with the other studies already published, we can see that we had the same percentage of cases with growing of the nodule, and the same percentage of cases with lymph node metastasis appearing. The enrollment is continuing. Now we have 171 patients on active surveillance. Altogether, 26 patients drop out for personal reasons, 6 patients enter into progression, and 139 are still on active surveillance. So the percentage of progression is still comparable with those that we know. All of them are cured by surgery. What about the clinical features of enrolled patients? We have almost the same situation that Dr. Sawka already showed for her series. We have young patients, 36% of patients are under 40. We have also cases with the family history for papillary thyroid cancer, and even cases with previous external radiotherapy. We have cases with autoimmune thyroiditis and different spectrum of patients. We had also our own experience about pregnancy and menopause. 5 patients under active surveillance had the pregnancy during this strategy, and we had no evidence of tumor growth neither during pregnancy nor after delivery. We had also 9 patients who developed menopause during the active surveillance, and we did not have any evidence of tumor growth. In 4 patients, we have even the reduction of at least one of the diameter, and 2 of them, the reduction happened in all 3 diameters. Just a few words about the concept of growing and how to choose the parameters to verify the growth of the nodules. Volume has been evaluated as another parameter that can be considered respect to the increase of diameter. This is a Michael Tuttle study showing that if we consider as a growth, a significant growth, an increase of more than 50% of the initial volumes, they have 12% of cases growing in 23 months of follow-up, while considering the increase of the diameter, only 3.8% growth in 34 months. And this is our experience, very, very similar. Regarding the increase of volume bigger than 50%, 70% of our patients had a progression according to this parameter. But indeed, in this subgroup of patients, only 3 had a real increase according to the concept of lymph node metastasis and increase of diameter. So if we consider the volume, probably the number of patients who has to be shifted from active surveillance to surgery is much bigger, and personally, I am not sure that this is the right parameter to be used. Here, without entering the details, is the algorithm that we use now in our clinical practice, and we propose the active surveillance to all patients with micro-PTC, and then according to their choice, active surveillance or surgery is performed. So as a final consideration, we can say that active surveillance is a valuable strategy to offer to patients with micro-PTC and likely also for bigger PTC. Active surveillance can be offered to young patients, to familial cases, to irradiated cases. It is likely that these cases will need interruption of the active surveillance because of growing, but in any case, some or several months of normal thyroid function can be gained. Patients choosing active surveillance have a lower level of anxiety respect to those who prefer immediate surgery. Volume increasing is, at least in my personal opinion, less appropriate than the increasing of the tree diameters to identify cases that must interrupt active surveillance. Longer follow-ups will provide stronger evidences about the feasibility and safety of active surveillance, but least but not last, we have to remember that active surveillance can be interrupted at any time. And thank you for your attention.
Thank you very much here. Those were two outstanding presentations. I want to get in two quick questions, and then I'm going to let Dr. Robenstock ask two as well. These two are for Dr. Sawka. Anna, was there any attempt to dissuade preconceived notions about the risks of thyroid surgery as it relates to calcium or the need for thyroid hormone replacement, or was that just accepted as kind of what the patient's notions were? And on a follow-up to that, was the risk of lifetime progression part of the initial discussion before patients chose which path to take?
Yes. So both of those excellent. Thank you for those excellent questions. So remember the surgical arm. We were kind of really trying to integrate this with a tertiary care center referral practice. And so the last thing you want to do is actually take the surgery away from the surgeons who are referring these patients to your study. So actually, in terms of the surgery, what was mandatory is the patient had to have a surgical consultation before, or concurrent, but essentially before they could really consent to the study. They could find out about the study, but till they could consent, they had to have a surgeon speak with them about what is the specific surgery that would be recommended, be it hemi or total thyroidectomy, what would be the risk. Because remember, patients would not necessarily come to our surgeons, and they needed to know the risks, et cetera, in the place where they'd want to do the surgery. So the referring, usually be a referring surgeon, but if they didn't have a referring surgeon, we made sure that they had a surgical consultation wherever they wanted. And we actually made it very much kind of usual care. So we did not dissuade them. If a patient asked you a question to clarify something, you could do that. But really, the surgical counseling was surgeon specific. And it was not actually something that we deliberately actually didn't want to sort of protocolize that and tell surgeons how to operate or how they're, to talk about their complication rates. So that was part of it where we discussed now you talk about lifetime risk of progression. Well, where are you going to get that data, Mark? Because if there's not long enough data to say lifetime. These are all survival curves that are extrapolated based on, at most maybe 10, the Kuma hospital obviously has the longest term follow-up, but you don't have really meaningful lifetime data for some of these groups. That being said, the lifetime data for an 80-year-old, you probably have a pretty good idea. So we presented the longest term data we could kind of find at the time, and those were really the Kuma hospital experience is what we presented, but we also gave them the proviso saying, look, this is in microcarcinomas, and you have a microcarcinoma or you don't have a microcarcinoma. We'd explain to them their tumor size in the context of that form of labeling. And so we also explained to them that really for patients who are, say, a 1.9 centimeter papillary who's enrolled in our study, we don't actually have that kind of long-term lifetime data. So we emphasize the uncertainty in what we didn't know. And we presented the best, and we provided them with references, et cetera. on the longest term follow-up we could find, which was really largely based on the Japanese data for the active surveillance. For surgical outcomes, we could give them average progression rates and that kind of thing, survival rates, but really the surgical complications and the details had to come from the surgeon who would be doing the operation.
Great. Eyal, let me give you the last final word here.
Okay, so I have one question. At the beginning of your talk, Anna, I wanted to ask if you use decision aids and things like that. But then
No.
But then you mentioned that most patients already made a decision before coming to see you.
Yeah.
We always discuss the physician, the patient. So what about social media and other means of decision making? Do you have any feeling about that?
Well, we obviously couldn't study it, because patients, they knew about the study. They had to be referred by, well, they could self-refer. So we did actually have some patients who self-referred, but they had to have seen a surgeon, at least a surgeon. Sometimes they saw a surgeon and an endocrinologist. So we knew that the study information, we did put some study information on the web. It was registered on clinicaltrials.gov. I'm not really sure how much talk there was on social media. At the time, what we did find, and maybe the situation has changed, but when we started this, patients would call the local survivor groups and they found no information. So they would go to their sort of those kind of sources, and it was so new that they couldn't really find it. What many patients did is actually look up the papers themselves. So some of these were highly educated individuals. They actually read this, they read the papers from Ito et al. Even before you talk to them. So some of these were very highly informed on their own, and not just social media, scientific literature.
Okay, that's fascinating. So
If I can I have just a few words?
Yeah.
Sure.
We have the same experience. In the beginning, the patient choice was one-to-one when we asked if they would prefer to have active surveillance or surgery. But nowadays, the majority of patients enrolled in the active surveillance program arrived to us as a referral center to perform active surveillance. So it's something that is becoming more, let's say, popular among patients, and they ask for active surveillance.
Great. Last questions here for both of you. Rossella, you've put a 1.3 centimeter upper limit for enrolling patients. Is there any thought to increasing that as per Anna's eligibility?
Yes, we are amended our protocol because we want to arrive at least to 2 centimeters, because the clinical feeling is that we can perform active surveillance also on this type of tumor, at least until 2 centimeters. Yeah.
Great. And finally, Anna, as you sort of enroll patients from all over Canada, do you have any concerns about the level of consistency and ultrasound expertise to be able to maintain good surveillance? That's sort of that lingering concern. Do you have thoughts on that?
Yeah, so we actually thought about that quite a lot. And so we actually have our lead radiologist, Sangeet Guy, has written a paper on sort of elements of this. So that's actually available. But we actually, patients are required, if they're having active surveillance at some of these other sites throughout the country, to have their ultrasound performed at the institution. So they're not getting them done in the community or other practice settings. So it is standardized. We meet with the radiologist and the or whoever's doing the ultrasound, is sometimes endocrinologist, radiologist, surgeon, etc. So we meet with them, we provide them some training, and we are also a resource to them if they have questions, for example, about location, etc. So we actually do provide some training. And that had to happen in our institution too, where Dr. Guy was the lead. He taught the other radiologists what to look for, and it actually became really kind of a knowledge translation experience directed at the radiologists, which has been actually very positive.
Terrific. Well, with that, it is once again my pleasure to have you join us. Dr. Robenstock did send me an email telling me that we needed to be extremely polite to you this morning because of your role in thyroid. And if we ever wanted to publish in thyroid again, we had to roll out the red carpet. So with that been said, thank you once again. I'll thank you as always, Rossella, and hope that everyone will join us again next week. Thank you.
Bye.
Bye. Bye-bye.